Welcome back after lunch, everybody. We are directly moving on to the next session. How useful is echocardiography? As chairperson of this particular session, I would like to invite on the dais Dr. Robin Chakraborty sir, Dr. Kanak Kumar Mitro sir, Dr. Hemendra Pandey sir, and Dr. Arindam Pandey sir. Welcoming all of you on the dais. First speaker of this particular session, Dr. J.C. Mohan sir.
Good afternoon. Just a few words before we start this very important session. Every day, the horizon of echocardiography is expanding, and we have learned many things about its experimental stage, research stage, but this coming session is I think one of the most important sessions, that is the clinical application or utilization of the echo in various clinical scenario. So let us start, and we have very prominent speakers in this session. So first topic would be 60-year-old shortness of breath and history of aortic valve replacement 5 years ago. And speaker is no other than Dr. J.C. Mohan from New Delhi. Sir, Dr. Mohan.
Thank you, chairpersons. Good afternoon, ladies and gentlemen. This was originally a presentation by Dr. Samir Srivastav, who couldn't make it because of personal reasons. And day before yesterday, Deepuda said if I could take over this session, and I thought, why not? And then I looked at this, the topic. It says 60 years old person, old man, short of breath, and had history of aortic valve replacement 5 years ago. And I had a number of cases which I could present, but I'll present to you a case in which you would have far more interest than had I presented a case of post-AVR prosthetic valve thrombosis. So let us look at this case. So this is a 60 years male who underwent aortic valve replacement by an Epic Supra 25 size valve by my friend GKM in 2011. Remember, the valve is Epic Supra, so it's a bioprosthetic valve and is a size 25. Normally, you don't put 25 size valve in the aortic position. You know, aortic position typically valves are 21 and 23. So he presents with shortness of breath after 5 years of implantation. He is symptomatic, and physical examination shows a basal ejection systolic murmur, LV apex, and ECG shows LVH with strain. I would show you the ECG. But first, a few words about the Epic Supra valve. It is a flexible polymer stent with individually selected porcine leaflets to ensure optimal coaptation, and a flexible sewing cuff designed to minimize both in-plant suture drag and post-implant paravalvular leak. This is how a Epic Supra aortic valve looks like. So it has 3 leaflets and 3 stents. These posts which you are seeing have a 9 millimeter height. These are all called stents actually. So have I gone overboard with that? Let us, okay. So I thought I will give you some idea about the prosthesis. So obviously somebody who was doing all right for 5 years and now has shortness of breath, of the myriad of causes you can think of, one of the causes could be related to bioprosthetic valve dysfunction or prosthetic valve dysfunction, let us say. That could be wear and tear of bioprosthetic valve, fracture of the bioprosthetic valve, calcification of the leaflets, leaflet tear, which is time independent and can occur any time, stent creep, which we would actually discuss in detail, and thrombosis. Thrombosis tends to occur more often with the metallic valves, but also bioprosthetic valve also thrombose. One of the things which we realize after TAVI is that subclinical bioprosthetic valve thrombosis is not an uncommon phenomenon. This is the electrocardiogram of this individual. Remember, patient is now in the 60th year, and this is his electrocardiogram. So the patient is in sinus rhythm. There is no left atrial overload. There is evidence of left ventricle with strain, and you could call it digitalis effect. Patient is not on digitalis, that reverse hockey stick appearance in V6. But patient has evidence of left ventricular hypertrophy, and how is that? By using Cornell criteria. Cornell criteria says in AVL, the R wave is more than 11 millimeter, it is left ventricular hypertrophy. So look at AVL, the R wave is something like 17 or 18 millimeter. Actually, it is a modified Cornell criteria. Original Cornell criteria was R in AVL plus S in V3. And S in V3 here is actually 30, and that should be more than 25. So you have already a situation where the left ventricular hypertrophy is present. I was talking in the morning during the award session, I said we should discuss more often ECG also in these sessions to keep the interest of young people in electrocardiography. So remember, we said 60 years gentleman who had an AVR 5 years back, and he is short of breath. So this is his parasternal long axis view. So what is there in the parasternal long axis view? You see some degree of left ventricular hypertrophy, a mildly enlarged left atrium, one could measure, and of course the thin leaflets, but the bioprosthesis is cone-shaped. There is inward bending or inflection of the stents of the bioprosthesis. You can see in a magnified view the same thing. Note carefully the stent or the post of the bioprosthesis, which is anterior. Note very carefully, look at the way the stent looks like. We would discuss this in detail. But you do note that both visible stents, you are supposed to have 3 stents, but in a parasternal long axis view, you will see two pillars only. Both pillars are inward moving. They are actually flexible inward moving, but also they are not parallel to the aortic valves. These are making an angle compared to the aortic valve. The angle is something like 40 degree anteriorly and about 30 degree posteriorly. Mitral valve seems normal. So this is just to show that the left ventricle systolic function normal. So this is not the cause for shortness of breath. So normal leaflet thickening. So left side, picture on left side would show you all the 3 leaflets. Within that triangle, all the 3 leaflets are not thickened. They have a normal motion and normal coaptation. Keep looking at these leaflets carefully. You can see all the 3 leaflets and normal coaptation within the, okay. So but look at what is happening actually. The left ventricle outflow tract shows tunnel-like sphere obstruction, which is starting actually at the level of the base of the, at the sewing ring, and is going right up to the tip of the posts or stents, tunnel-like. And you might consider maybe this is thrombosis of the bioprosthesis thrombosis. The vena contracta is 8 millimeter, which is slightly generous. You again see a 5-chamber view, and you see that the flow is going through a very narrow tunnel. The flow is going through a very narrow tunnel, and of course there is pseudo-normal left ventricle function. So the cause of dyspnea probably is this grade 2 diastolic dysfunction. But why is that? So let us look at the hemodynamics of this valve. So the Left ventricle outflow tract VTI is 25, indicating nearly normal stroke volume. And the aortic valve, the DVI, the dimensionless velocity index shown is 0.32, which tells you that it should not be severe aortic stenosis, but we'll come back to that thing. This is looking at the continuous wave Doppler interrogation of the valve, and you have a peak velocity which slightly exceeds 3 meters per second. However, it is not showing late peaking, and if you were to measure the acceleration time, you would find it probably less than 100 milliseconds. So on the face of it, the gradients are increased. The gradients are peak gradient 34, mean gradient 21. Velocity time integral is 69 centimeter. So you are getting an aortic valve area 1.1 centimeter square. You might say, well, that is moderate aortic stenosis, and why should patient be symptomatic, if at all? Remember one thing, that this is how the Bernoulli's equation is. Bernoulli's equation, you know that when the flow is passing through a narrowed segment, there is much more energy converted to kinetic energy, total energy converted to kinetic energy, and the potential energy or pressure energy drops, so the velocity increases, and then once you go across the obstruction, the kinetic energy gets converted back to potential energy, and you get actually velocity drops. However, this Bernoulli's equation needs to be understood very, very carefully, because it applies to a discrete stenosis and not to tubular stenosis. In tubular stenosis, there are two things, convective forces and accelerative forces. In modified Bernoulli's equation, which is delta G equal to 4V square, you are ignoring accelerative forces. In a tubular stenosis, accelerative forces are much more important, and hence you may get lower velocities and still the stenosis may be significant. This patient represents an example where when you see very narrow tunnel, I again would show you a very narrow tunnel so that you understand the whole concept. This tunnel is very narrow, see on the left side. If you were to be asked actually what will be the valve area, you would know that this is a severe stenosis. You don't need calculations. But when you do calculation, the valve area comes to 1.1, and you might say, oh, it's not terribly bad. It is terribly bad. So again look at the narrow tunnel. The leaflets are all right, but the tunnel is pretty narrow. So let us show you the leaflets again better. Whatever leaflet you are able to see is better, but again try to imagine what we are trying to show you. And the left picture will show you better. The posts are coning. These are actually making a pyramid. Let me show you a little better. But before that, at the base, this is the triangle. At the base, the leaflets are all right. At the apex, the triangle made by 3 posts is narrower. Try to understand that again. This is a wide triangle. This is a wide triangle. You need to measure the area of this triangle by a formula. And you need to measure the area of this triangle, which is small. At apex, area at the apex of this valve, the triangle is narrow. The triangle is wide at the base. The ratio between the two is called stent creep ratio, which is 0.65 in this particular case. Let me show you how do you measure it, but for a moment again look at the leaf. I don't think I'm doing it justice. This is not a great picture, but this is how you measure the stent creep ratio. Stent creep ratio is area of the triangle at the base. The triangle area is calculated as 0.32 into internal diameter squared. So here at the apex you are getting 1.18, and at the base it is closer to about 1.9, so the ratio comes to about 0.69. This is how you look at the area of the triangle at the apex. This is just an example of a 21 Edward prosthesis. So what does this patient have? Now let me just try to explain. We have confused you enough. This particular patient has bioprosthetic dysfunction by a phenomenon called stent creep. Stent creep is an uncommon mode of structural deterioration of bioprosthetic heart valve defined by permanent inward deflection of the stent post. This inward deflection of stent post does not allow the leaflets to open. Leaflets are all right, but they just don't have space to open. You may have a beautiful car, but if you don't have space to take it or spin it around, you can't spin it. So you have no space. And this may occur because of valve oversizing. Remember, our patient had an EPIC 25 size and leads to intrinsic valve stenosis. But this is not the only thing. So this is a diagram to show you. That is the base of the prosthesis, that is the apex of the prosthesis. This is what happens. Because the leaflets are constrained, they don't have space, you have this kind of orifice area which is much narrower than what would you expect from the base of the prosthesis. 21 size has an inward diameter of about 20 millimeter. By that, actually, you will get a much bigger area, but that is, so diagnosis of stent creep is usually made from subjective observations of inward bending on echocardiography or fluoroscopy. You saw inward bending. Clinical incidence of stent creep and its impact on modern stented bioprosthesis are unclear. In some cases, it may be the only cause of bioprosthetic dysfunction, like in my case, and it can occur anytime. It's not time dependent. It can occur within 3 months, within 6 months, or maybe after 5 years. So the possible etiologies of stent creep are small aortic root implanted with a relatively large bioprosthesis. This seems to be the case here. Traction of the stents due to overlying cloth tissue ingrowth. Cloth tissue ingrowth can also occur actually. Remember, there is an interface between the cloth covering the porcine valve. And of course, incompetence of the diastolic flow causing circumferential contraction. Remember, the aorta expands during systole, it contracts during diastole, unlike left ventricle. So aorta expands during systole, contracts during diastole. When it contracts during diastole, it puts pressure on the stents, which tend to move inwards. And there can be, of course, mechanical fatigue of the stent material, which can also create this thing. How to measure stent creep? You can measure the bending angles of stent post, projected outflow area, and reduction of the tip projected triangular area, which is called stent creep ratio. The stent creep ratio normally should be 0.92. It should not, that means the angle should nearly be 90 degree, parallel absolutely. The 0.92 is what has been described normally. So the normal ratio is 0.92, a ratio of less than 0.79 associated with transprosthetic velocities of 4 meter or more. So and this phenomenon actually has been recently reported, relatively recently. This is a paper by Vinny Bapat. When he was in England, he reported 3 cases of successful treatment of failing biological prosthesis because of stent creep with valve-in-valve transcatheter aortic valve implantation. This is one of our paper. Dr. Madhu Shukla and me published this paper. Very early and unusual aortic bioprosthetic valve deterioration 9 months after implantation. So this is the patient which we published, and you would note here the leaflets are all right. Leaflets are all right. Oh, I'll show the moving picture. Now you can appreciate actually look at the right picture for a moment, and you would now appreciate the stent creep. Look at the stent creep here. Isn't it dramatic? This is our case which we published in 2019. So you obviously can read that the pictures are of 16th February 2016. And here is just to show you, when you look from the left ventricle outflow, from below, you can see the pyramid forming. Finally, you see the orifice getting smaller and smaller, the orifice being here that big, and finally the orifice getting much smaller here, much smaller, the black part, indicating that the leaflets are not able to move. So this is actually the case which we published in 2019, and the extreme right picture would show you where the stents are lying at the apex. At the apex, the stents are so much crowded in the sinuses that the leaflets are normal, but there is marked turbulence. Shantanu, you are not allowed to sleep. You got to get up. When I am not sleeping, how can you sleep? So let me summarize the case. Because he is sleeping, I need to summarize. I won't show any more pictures. It is important to distinguish leaflet dysfunction and stent creep in a bioprosthetic valve. Because if there is a stent creep, the treatment is transcatheter aortic valve-in-valve implantation or a surgical implantation. So again, a stent creep is defined as inward inflection or bending of stent post, and I just showed you a case like that. Thank you. Questions?
Thank you, Dr. Mohan, for presentation of this excellent case, relatively uncommon cause of bioprosthetic dysfunction. And I think everybody present here, we are enriched with this presentation, which apparently shows the normal echocardiographic parameters, and you have shown how to detect this uncommon dysfunction and the remedies. So thank you again, Dr. Mohan, and just a few questions may be allowed for this interesting case presentation. From the floor, any questions?
Pardon?
The oversizing cannot be picked up post-operative?
No, oversizing one of the mechanisms, but a perfectly normal size valve also shows stent creep. There are multiple reasons. The material degeneration is one part, the circumferential diastolic contraction is another part. Constantly aorta contracting in diastole can also move it. This is something you can't always predict, but we actually were observing the same phenomenon. Remember the first case I showed you, 2011. We did not report it. Why? We didn't even understand what is happening. Till Vinny Bapat in 2015 published a report of 3 cases, and we woke up. We said, what is happening there? So eyes don't see what the mind doesn't know. So that first case I presented was 2011, and for a good number of years we kept scratching our head, what are we dealing with? It is only when Vinny Bapat published that we came to know there is something like stent creep. We went back and saw our patient, and I thought I'll present to you. The second case we were wiser. Although we saw in 2016, by that time Vinny Bapat had already published this report in Cath and Cardiovascular Diagnosis of 3 cases. So we were quick to publish it, and it got quickly published. Madhu and me wrote this article very quickly. Actually, if you go to the original publication, I strongly suggest you see the original publication. Pictures are great. They are fantastic pictures we have placed. But you can't reproduce here those pictures. Yeah, please, sir.
Dr. Mohan?
Yeah.
Ajay, yes.
My question is, why does the stent creep in? I mean, it bends inwards and not outwards. The flow is from LV to out to the aorta.
No, the point is, during systole, the aorta is expanding, right? Flow is going. Now the post will go out. During diastole, they'll come in. There should be some flexity. What happens is this constant phenomena at the base produces a fracture kind of thing, a defect kind of thing, that now they are inward bent and they can't move out that much. So they become in a fixed position or relatively fixed position. So this is now a pyramid. Instead of being like this, they become like this. So the leaflets are constrained.
How frequent you are seeing this?
I have actually 4 cases. How much is reported in the literature? But we are talking of these 4 cases who do not have valve degeneration. So when we reviewed the literature, the only report we have found is of Vinny Bapat. Vinny Bapat report. We have not found other, but others have described stent creep along with leaflet degeneration,
Only in the bypass technique.
only in bypass. So the people have described both together. So there is a report of 22 cases of bioprosthetic degeneration in which one case had isolated stent creep. That is in 2019. So you can imagine that this is a phenomenon on which your and my attention hasn't gone in that detail as it should be.
One thing, doctor, I have a question. Patient presentation was due to shortness of breath.
Yes.
And patient has a dysfunction. But whatever parameters we have seen in echo, it is not very significant as far as gradient is concerned, as far as is. So whether there is a clinical and this findings correlation, whether this dysfunction is causing the shortness of breath, or it may be a chance finding that we have seen some abnormalities in the routine echo and we further go beyond that.
You are very right, actually. So let me explain. First thing is we are underestimating the severity of stenosis. Patient has evidence of left ventricle hypertrophy. Patient has evidence of grade 2 diastolic dysfunction. Left atrium is enlarged. So the patient has typical what you will call aortic stenosis related dyspnea causing hemodynamics. So it's not that the patient is asymptomatic. And asymptomatic patients, they don't turn up to physicians like us. Patients turn up only when they are ready to pay money to be seen actually by a consultant. The fact is that, so what has happened is over a period of time, significant aortic stenosis has occurred, some degree of left ventricle hypertrophy, LV diastolic pressure got raised, LA pressure got raised, and the patient started becoming symptomatic because of increased wedge pressure. That is how the patient has come to us.
LVEDP is increasing. Whatever.
You see, in a 60 years person, that transmittal flow pattern is almost always grade 2 diastolic dysfunction, almost always. At 60 years of age in India, the E becomes much smaller than A wave. I mean, you, remember work done by Roxy Senior long back, we age faster. So by 60 years of age, if you have your E wave bigger than A wave, it is not normal. Something is abnormal. So I didn't show you tissue Doppler, but the tissue Doppler was also the filling pressure were elevated.
Okay, very, very nicely discussed. Thank you, Dr. Mohan, again. So
Thank you.
probably you will be present your
Yeah, I
own
will
case
quickly
now.
present another case and then take some break.
And it is the case of VT.
This was the original case I was supposed to present. 45-year-old lady presents with VT, had a pacemaker implanted 2 years back for AV block. So why should patients, pace patients should have VT? It could occur because their scars are present. It could happen because there are intramural reentrant circuits. It could happen because there is an evolution of a new arrhythmia substrate caused by pacing or pacing-induced cardiomyopathy, or there can be pacemaker malfunction. Ventricular scars are metabolic, active, and dynamic. So it is possible that the patient, even at the time of AV block, when pacemaker was given, had scar which are now become active. So VT in this lady could be pacemaker-mediated tachycardia. We all are aware of that, which is actually an upper rate behavior, nothing more than upper rate behavior. It can be pacemaker malfunction. We don't see the runway pacemaker any longer, but occasional runway are described even in 2022. So I am surprised. So the VT in this lady could also be because of myocardial disease and of course because of ischemia. Pacemaker mediated tachycardia is because rate response setting that is too sensitive, sensing atrial noise and tracking of atrial arrhythmia, they all can cause a rapid VT kind of thing because it is basically A sense V pace. So V pace will be wide, so it will, so if there is a noise being sensed by the atrial channel, you will get a ventricular tachycardia to the limit of upper rate behavior. If you have kept the upper rate at 140, you will get VT up to rate of 140. And of course, endless loop tachycardia in which pacer is antegrade limb and the VA conduction, AV node or VA conduction is a retrograde limb. So we keep seeing these cases and we know how to handle it. The other thing, of course, the VT can occur is because pacemaker can be pro-arrhythmic. Remember, the lead actually can also create problem. Many times you put a pacemaker and the patient starts getting NSVT. Spike on T wave, that also can occur because of you didn't fiddle with the refractory periods that well. And of course, I talked about endless tube tachycardia, new onset ischemia. However, you can also have polymorphic VTs because of continuing changing ventricle activation sequence, often associated with changing arrhythmia substrate. How can arrhythmia substrate change? Either as a result of acute myocardial infarction, acute myocardial ischemia, or metabolic derangements. Did you call me to talk about this? No, certainly not. You want me to present to you something which is more dramatic. So let us again, before we talk of dramatic thing, let us again talk of possibilities in this lady. This could be a pacemaker-mediated tachycardia. It could be pacing-induced cardiomyopathy. It could be patient has a inflammatory myocardial disease, or patient has a TR-induced arrhythmogenic right ventricle dysfunction, or it could be miscellaneous. So let's get back. First thing first. 45 years lady, why did she get a pacemaker for AV block? So first thing which should come to your mind is suspect sarcoidosis in those who are below the age of 55 years presenting with AV blocks. And suspect cardiac sarcoidosis in those patients who have non-severe LV dysfunction with AV block. Cardiac sarcoidosis presenting with lone atrioventricular block can resist diagnosis for months and years, and in worst cases until death or transplantation. That is the first thing. So this is work by Dr. Narasimhan from Hyderabad. Unselected idiopathic AV block in age 18 to 55 years, and they decided to do FDG uptake of everybody. So they had 42% positive FDG uptake patients presenting with AV block below the age of 55 years. Means almost 40% patients with AV block, young, have inflammatory myocardial disease. Sarcoidosis being the commonest, rare cases of tuberculosis, and still rare, giant cell myocarditis. I want you to keep this slide in mind. Excellent work done by Narasimhan, and now we'll build up the story of this case, okay? And there is another thing which can happen. This was not the case. Maybe it is pacing-induced cardiomyopathy. And Dr. Madhu, actually in the afternoon, is going to present you a very unusual case of pacing-induced cardiomyopathy. But pacing-induced cardiomyopathy does occur in 6 to 26, average prevalence of 12%, and this is characterized by ejection fraction less than 50%, or ejection fraction fall of more than 10% because of constant right ventricle apical pacing, associated with raised BNP levels and raised troponin levels. Unless BNP and troponin level both are raised along with fall in ejection fraction, you should not call it pacing-induced left ventricle dysfunction. So predisposing factors in pacing-induced cardiomyopathy is a previous MI, baseline ejection fraction, pace burden, and pace QRS duration. But we'll discuss all these things in Dr. Madhu's case, not here. So we come back to our patient. 45-year female, average build, presented with a single episode of syncope, known case of type 2 diabetes on regular treatment. Now this is the point. You see a lot of patients with AV block and diabetes actually in the young. So what did we do actually? We looked at that ECG. The ECG showed bifascicular block. And she had a one episode of syncope. So she has right bundle branch block, and she has a left anterior hemi block. The axis is minus 75. The computer, the artificial intelligence reads a minus 60. My own reading is minus 75. PR interval is normal, but look at the QRS duration, 148 millisecond. Fine. So she had a Holter which showed intermittent complete heart block as a cause of syncope. So obviously she has CHB, she had this bifascicular block. We have to put a pacemaker. Should I do an echocardiogram? Do we do it? That's the question. Most of us don't do it. I mean, I as an implanter, when I get this case, complete heart block, I just put a pacemaker, get the patient out next 24 hours. My median stay of pacemaker patient in my hospital 20 hours. So I don't do any of these things. This is what most of us do it. But we should do it. That's beside the point. So these are the blood tests of the lady actually, nothing abnormal. Nothing which bothers us. None of the tests, except HbA1c is 7.6, and you will say, we should do something to this lady. 2 years back when she had HbA, obviously somebody must have up-titrated her anti-diabetic medications to get her under control. So she undergoes DDDR pacemaker implanted 2021 on treatment for type 2 diabetes and hypertension stage 2 CKD. Her EGFR calculated was something on a lower side, so she's on. Unfortunately, no echo. You don't get paid for echo. Pacemaker patient come for with a package. The package doesn't include echocardiogram. Fine. So I did talk to you about one thing that, remember, inflammatory myocardial disease often presents as an ostensibly idiopathic AV block in young and middle-aged individuals. Between 20 to 34% individuals below the age of 55, this is a world literature, this is not Narasimhan study, this is the world literature have inflammatory myocardial disease. So you should have considered at that time inflammatory myocardial disease. We did not consider, because this is exactly what I am trying to present. And cardiac MRI or PET should be used with a low threshold to seek signs of inflammatory cardiomyopathy in young and middle-aged patients with unexplainable high-grade AV block. Do you do it? Now my question to you. You get a person 50 years old with complete heart block, how many of you get PET CT done? Anybody who says, yes, we get it regularly done? No. So May 5, 2023. Now this lady gets admitted with an episode of palpitation and chest pain at SSB hospital in Faridabad. This is one of our boys who actually runs a big hospital, big entrepreneur actually. Surprises me actually is that guys who work with us have gone to that extent, actually running hospitals with an investment of thousands of crore rupees. It shows their entrepreneur skills, and people like you and me keep discussing only echo here. So ECG shows a monomorphic VT, cardioverted 50 joules, blood tests are done. Now the serum creatinine little high, anti-proBNP is 780 picogram, and serum creatinine is 2 milligram. Okay, that is the VT. This is the ventricular tachycardia she has presented. Morning of May 5th, it should read May 5th, not May 6th. Mistake at the top. But it is a monomorphic ventricular tachycardia, and of course, this is what it is, right? After cardioversion, back to, of course, bifascial block, you don't see CHV. So remember, she is having intermittent CHV, so you are not seeing any pacing, or you are not seeing any, so it is all being sensed. P is being sensed and QRS is being sensed, but the AV delay has been kept such that the patient doesn't pace in the ventricle. So that way we are smart. We are not pacing in the ventricle to prevent pacing-induced cardiomyopathy. So or maybe it is adaptive pacing, because the pacemaker now adapt. Actually, they would not pace. They will wait for the intrinsic QRS to come. Maybe it is adaptive pacing. Okay. So sustained monomorphic VT is usually due to re-entry in a region of myocardial scar in patients with structural heart disease. So we need to look for structural heart disease. Monomorphic VT, sustained monomorphic VT is because of a myocardial scar. It is not polymorphic, it is not a ischemia, it is not because of hypokalemia. This is what we have to look for. So we started looking, did an echocardiogram. Of course, you can see the pacing lead there, 2 leads actually. One is a pacing lead, another ICD lead later on actually. So that is fine. But the arrow points towards, in the left side, very thin basal anterior interventricular septum. It is actually measures just little less than 4 millimeter. But if you look at the distal, I will bring the laser pointer again. If you look at the distal septum, that is pretty thick, almost 11 millimeter, and this is just 3 millimeter, so you have a very marked disparity. One single thing, and we know the diagnosis. Why do we know the diagnosis? Basal IVS thinning defined as thickness less than 4 millimeter or equal, or basal IVS to IVS ratio of less than 0.6. could be used as a criteria to diagnose cardiac sarcoidosis with a 99% specificity and 39% sensitivity. Its sensitivity is less, but its specificity is so high. There is no other condition in which it occurs. But we have seen this thing happening in two other conditions, that is tuberculosis and SLE. Tuberculosis and SLE. So the specificity 99% might come down a little bit, but this is the work from Japan. So the cardiac sarcoidosis presents with AV blocks, heart failure, VT, and sudden cardiac death. And let me show you more pictures of this patient. And lower down are the causes: sarcoidosis, tuberculosis, SLE, ischemic. Well, we have not seen ischemic, and of course other types of myocarditis. Forget it. We will continue to go back, and of course ejection fraction is 39%, not too bad actually. And we did have some global luncheon strain. I'm forgetting, probably 13, 14. But nevertheless, patient is asymptomatic. Ejection fraction calculated was 39 to 46%. Enteroseptal basal scar, VT, agrees for ICD. And of course, a new lead is placed and ICD is implanted. And the RV lead is now capped, because the same lead can be used for pacing this thing. So we saw the right ventricle, which was all right, nothing wrong with the right ventricle. And so isolated cardiac sarcoidosis is not diagnosable in the absence of positive histological finding. However, FDG uptake can be a surrogate. So FDG uptake preferably should be done in all young individuals presented with the AV block. And in case you have not done it, we have a poor man's choice, and that is do an echocardiogram. And echocardiogram will pick up burnt out cases. Probably the early active cases one may not pick up. In this particular individual, now we did an FDG PET CT uptake, which was negative for any active inflammation. So we did not do anything for this patient. So let us review the literature in 2 minutes. This is a study what is called as myocardial inflammatory disease from Finland, MIDFIN group. MIDFIN group says 1/4 of unexplained AV blocks in adults below 55 years of age are caused by cardiac sarcoidosis. and AV blocks requiring pacemaker implantation is the most common initial manifestation of cardiac sarcoidosis. This is a whole population-based data, whole of Finland they are talking about. And this is how the patients present actually, MIDFIN study. Most patients present with low atrial fibrillation, the blue part. Some present with low ejection fraction, and some present only with VT. Most of the people present with the AV block. And of course, the number, they're diagnosing more and more. So like us, they're also getting smart, or like them, we are also getting smart. And we are diagnosing more and more of this thing. So you can understand that from 88 onwards, they are diagnosing more and more such cases. Differentiating cardiac sarcoidosis from idiopathic dilated cardiomyopathy, for that matter, if somebody presents with AV block and has some LV dysfunction, high frequency of complete heart block is more common in sarcoidosis. Right bundle branch block, like our patient had, is far more common in cardiac sarcoidosis, and abnormal left ventricle wall thickness is more common, and more common ventricular arrhythmias. And of course, prognosis-wise, VT-VF has a bad prognosis. We would, rare causes who present with AV block and later may have VTR, ARVC, systemic lupus and pacing-induced apical wall motion abnormality. Dr. Madhu will present the case. Should I present case number 2? No, I don't think I intend to present. Thank you very much. I'll stop here.
Thank you again, Dr. Mohan, for presenting again a good case. As there is no speaker, so we can have some discussion. Two important issues can be raised and discussed here. Number one is whether all patients presenting with complete heart block should be done echo, so mandatory it should be done echo, and whether MRI should be done or not. Number two, if MRI picks up some abnormality in the basal septum, even if the patient is not presented with VT, whether we should put ICD or dual chamber pacemaker. So these are the two important issues. In an asymptomatic patient, MRI picks up basal thinning, suggestive of some sarcoid.
And there is AV block.
AV block, but patient have no symptoms of VT.
Yeah, so there is a class 2A indication for putting an ICD in all these patients. Everybody who has actually basal septum thinning or has evidence of localized inflammation suggestive of cardiac sarcoidosis and AV block, ICD, dual chamber ICD is the way to go forward.
So I hand over to my co-chairperson.
Dr. Shubhra Banerjee wants to.
What if we treat the sarcoid? What would be the chance of having a recurrence of VT in a treated case of sarcoid?
This question has been answered by the guidelines. The Heart Rhythm Society guidelines say treat and still put an ICD.
Any more questions?
Septal thinning, basal septal thinning occur. Why does it occur?
So actually, for unknown reasons, sarcoidosis involves the base of the heart, mostly. So either basal inferolateral wall, which is called type 2 sarcoidosis, or basal anterior septum, which is called type 1 sarcoidosis. Why does it happen, and why does tuberculosis have the same predilection? We don't know actually. I have no idea why an idiopathic granulomatous disease should involve the basal parts of the heart. Similarly, I don't know why Anderson-Fabry disease should involve basal infralateral wall. I have no idea.
Does strain imaging give you early hint that the basal portion is going to get affected before there is actual thinning?
Yes, enormous amount of data that people with pulmonary sarcoidosis without obvious cardiac involvement have lower strain values. You are absolutely right. We should use strain more often and try to actually keep a note of that.
Regional strain or global strain? Regional
No, the
strain.
global strain. We, at the moment, recommendation don't talk about regional strain. So you should not, you should use regional strain actually as a prop, but always talk of global longitudinal strain. Yes, because of granuloma inflammation, there can be regional thickening. You can see, you have a good question. I wish I could show you a case, but I don't know where it is. I'm not using my own laptop. So I'm using their laptop. So I can't just go on and find out, but I could show you the case. So whenever you see this regional thickening, regional kind of granuloma, I think the next thing is to do FDG, PET and or MRI, ideally both. And then of course immunosuppressive therapy, preferably with steroids. And some people use methotrexate, some may use even cyclophosphamide, some may use hydroxychloroquine, and the others have used many other things. But steroids are the main therapy, 1 milligram per kg of body weight for 6 weeks, then taper it out. And people have done well. Narasimhan has a protocol. You can go and check a protocol for that. He, I think, has one of the largest series in the country.
And since it's said that it may involve any part of the myocardium,
Yes,
both of
but
LV
preferably
and
basal, but any part. Even apical aneurysms are described. Even mid-septum is described. And again, I don't have my own laptop. I would have shown you the whole spectrum of cardiac sarcoidosis.
So localized thickening of the myocardium should,
Yeah,
we should
localized thickening, which is
true?
relatively hypokinetic.
relatively high.
But you know, having said all this thing, the specificity for basal septum is, basal anterior septum and basal inferior is so strong that
Yes, sir.
sensitivity is low, but specificity is very high.
Yes, sir, I have few cases of basal septum involvement. That is the commonest finding we get. But the hypertrophy, I think I am missing.
Yeah, we are missing a lot of cases. I think our suspicion should be pretty high. We still feel that. Yeah, we are picking out burnt cases. The reason is when they come with fever, arthalgias, body aches and other things, we don't do echocardiogram of these people. When they start with cough, they go to a pulmonologist who doesn't get echo done at all, who doesn't believe in echo.
But do they require a coronary angio also to have a differential diagnosis of wall motion abnormalities?
Oh yes, you should do it, but if this is the wall motion abnormality, I wouldn't do it. But you'll be surprised, this lady had an angiogram, not by me, by SS Bansal. I don't know why he did it, but it was normal. So it is interesting. I did not prescribe, But SS Bansal did an angiogram of this lady in 2019, even before she had an AV block. She had diabetes and hypertension, she had done a coronary angiogram already, which was normal. Yes, yes, absolutely, absolutely. Yeah. Thank you very much.
Thank you, Dr. Mohan. Now I invite Dr. Shantanu Sengupta to give his presentation. Sudden hypotension in a 70-year-old man on the 4th day following surgery for acute intestinal obstruction.
Yeah, thank you so much. Again, a clinical case with an echo-oriented approach. So whenever somebody, an elderly person, 70 years, comes to, we get a call for an hypertension assessment following a surgery for intestinal obstruction, you start thinking of the following causes, whether there is is the person hypovolemic, has there been a blood loss, evidence of any sepsis occurring, any coronary new fresh event happening, or is it stress-induced cardiomyopathy? Remember that stress-induced cardiomyopathy is unlikely, can occur, but if this kind of episode occurs post-operative, immediately or in intraoperative, then mephentamine has been one of the possible mechanism to cause a Takotsubo kind of picture causing hypertension. So these are the possible things which I could think of. So remember, the role of echo comes to understand the hemodynamics and how to approach them, because it is just like knowing the emotions in a critical care setting. The most important thing is that many times this kind of patients do get a central line to understand, but what I'm trying to show is that can we pick up the values by doing an echo, and echo is a very integral part. So we generally call for this blood reports. So by the time the blood comes on the 4th day, the first thing, as we were discussing yesterday, is to look at the IVC in a patient who is maybe around 80 systolic, to see what exactly is happening. So this was one of the patient, and as you can see, the IVC is smaller, 1.1, so collapsing. So the pressures are low, and this is one of the suggestions of looking at the IVC, understanding that the recommendations still give a cutoff of 2.1, but in my area of the side where it is relatively drier, still the 1.7 things goes up. So anything wherever, if the patient has an IVC size of less than 1.2, we start realizing that this patient must be hypovolemic, so a fluid challenge always helps. Couple of more images by the time we are getting the levels. So this was what is there. You can see there was some amount of LV systolic dysfunction. In a patient, heart rate was around 100, 102. The patient was hypovolemic still. So the next thing should come is to look at the stroke volume. What is the stroke volume by this formula? Remember that our normal values are around 1.8 to 2.2 of the LVOT diameter, and the LVOT VTI is around 18 to 22. So if you look at the LVOT VTI directly by looking at the apical 5-chamber view, you will get an idea what is the problem. So this also helps, and it is very easy to get. So once you get an apical 5-chamber view, so this patient's LVOT diameter was around 1.9. The VTI was 13.3. We could get the stroke volume and the cardiac output from it. So this patient was slightly hypovolemic. The LVOT VTI was lower. And so this gives you a lot of information. Also add on to get the LV ejection fraction in such kind of patients. So the biplane Simpson was lower, but remember this patient started having some evidence of hypokinesia. There was no previous echo report available, so I was not knowing what exactly was the cause. Of course, troponin was also sent for this to understand. So this is the way you start approaching a case, look at them, get the filling pressures, the E by E prime, the E was around 0.7, the E prime velocity was low, the E by E prime is 14. So it's a mixture of problem where the IVC is slightly collapsed. So what kind of treatment do we give? LA volume index was around 36 ml per meter square, so there was some diastolic problem. So these are the information we should always give and try to come up a couple of more images. You can see the septum was contracting less. So the interesting part that whenever you start looking at this, please also we have to have an information of the right ventricular side. Because just looking at the LV, just looking at the IVC, just looking at the stroke volume, you should not be satisfied, because the RV is going to give you an understanding how the patient is going to behave prognostically. So this was the images. As you can see, the RV, there was evidence of RV systolic dysfunction. The TAPSE was only 6.5 and RV S' was very low. So this is a problem. If you face, in RV, systolic dysfunction can have a poorer outcome, and you can counsel the patient that these patients are going to be difficult. So let me try to summarize that if you start getting a patient on the 4th post-operative day, and you have this information, more images, you can see there is evidence of some evidence of mitral regurgitation, understanding that we don't have any previous echo. So by the time we have this image, we have the values. Hemoglobin was around 9.4, counts were higher, polymorphs were higher, CRP was elevated. Fortunately, the renal function tests were preserved. Albumin was low. Most of the problem, any abdominal surgery, the albumin goes down. TROP came out to be negative, and the pro-BNP was high. So now we have a situation where we are getting a patient who is elderly, 70 years old, 80/60, having LV systolic dysfunction, mitral regurgitation, whether I would like to look at that E velocity with the presence of MR, but still the E prime was low, and presence of RV dysfunction. So my question to you is, what will be your best approach? What will you tell to the intensivist? And I want with the raise of hands so that we discuss. So, of course, we will up-titrate the antibiotics, we'll look at the blood, we'll call for the blood transfusion, understanding that there is hypoalbuminemia and some anemia. So what will be your best step? Would you like to give an IV fluids only, understanding that the IVC is collapsed, but there is RV dysfunction? How many for IV fluids? I'm just trying to make it, there is one IV fluid. Anything else? Anybody else? So how much IV fluid will you give, sir? What is your approach? Yeah, let's have mics. Let's have a discussion. And we are trying to, so what IV fluid and how much rate you will give, understanding this patient has RV and LV systolic dysfunction. Any thoughts? Can you give the mic, please? Sorry? Half liter over a period of half an hour. So around 250 ml over a period of 30 minutes is the point. Okay. So how many of you will think IV fluids and you will like to have, along with a noradrenaline infusion? You have 4, 5, 6, 7, okay. How much? Anybody can volunteer? How much will you give? So because just telling IV fluids and NORAD is not sufficient. Yeah.
Yeah, I think I would start with IV. I will give a bolus and
Okay.
see what's the rise in CVP or maybe PA pressure, and I will monitor the fluid as per that.
Okay.
Because too much of fluid otherwise can cause problems, so I will be
Right.
guided by the.
So how much will you tell?
I think there is a, I can't remember now, they said like give 100, depending on what's your current CVP is, you give some amount of fluid and look at the
So
rise
we
in
don't have a
CVP.
CVP. I'm sorry to tell
Okay.
you. We are not putting the, I'm
We'll
sorry,
go by-
we are
okay,
echocardiographers.
We'll go by the, okay, then we'll go by the echo features of IVC and see whether it's collapsing
I
or
think
not.
that's, yeah, so I think that's a very valid point. We can always give IV fluids and immediately look at the IVC, but do you think we'd like to give a noradrenaline infusion? Somebody said, let's have, I'm just trying to get the discussion. Somebody was telling noradrenaline, how much you will give? Okay, and what about the IV fluids thing? I think RV dysfunction 500 ml in half an hour. Do you think the patient
RV
is...
dysfunction, at least from the 2D picture, I was not. It was hyper or
Okay.
almost normal contracting, although you
Okay.
said TAPC was 7.
But if you see the RVS prime, it's not a very good image.
Yeah, but RV free wall is contracting reasonably well to me.
Dr. Mohan, your thoughts? And I think you are at the end. But this is a practical problem we face.
So I do understand that this patient has septic myocarditis.
Correct. Sepsis.
Patient has biventricular dysfunction, sepsis, RA pressure is normal, the LA pressure probably borderline.
16, 17. Okay.
I do have to believe that S prime is load dependent, and so this does show RV's systolic dysfunction, which is load dependent.
And we don't
Which
have
means
strain
if there
values.
is a reduced preload, S prime will be low. Okay, that is what I want. Now, the critical thing which I want to get in this patient is SVR, systemic vascular resistance. I would always measure cardiac output, and from the blood pressure, from the mean blood pressure divided by cardiac output multiplied by 80, I will get SVR in 9-second result.
So can somebody do it with a calculator? So he said a very important point is systemic valvular resistance is MAP. We have 80 by 60, so we know the MAP is around 72, will be around 72 divided by
Cardiac output.
cardiac output was 3.7 liters into, somebody's doing, sir, he's doing.
3.7 liter gives you 20 wood units, roughly. 20 wood unit means SVR is raised.
Raised.
You don't have to give NORAD, here you have to give fluids. If this is actually less than 12 wood units, I would definitely give combination of the two, but since I have 20 wood unit, my choice was to give intravenous fluids only. Now you might say that I have these values S prime, I think they are load dependent. As the load goes down, S prime goes down. The E to E prime of 14 on medial size doesn't bother me. I would rather give fluids, give antibiotics, and treat accordingly. And I will of course observe. With 20 wood unit, I don't have the heart to give noradrenaline, to be honest. It's already SVR is pretty high. I will be actually compromising tissue perfusion further.
Anybody has a difference of opinion? You can have it. It's a science. Anybody would like to have vasopressin? You have here. So SVR Sarastol is 20. You have an SVR of 20.
It cannot be. Because I tell you, with the amount of RV dysfunction which you
Even
are showing.
I think, sir, SVR may not be 20. I mean, it is too high.
And the size of the IVC and the collapsibility, it doesn't match.
You say the mean pressure is 72 divided by cardiac out 3.7. 72 by 3.7 is 20.
How much is coming here?
19.
19.
19.5. 19 is also high.
It's pretty high.
I wouldn't like to give.
I think 14 is the cutoff which I take. He's taking 12. That's pretty okay. So I think any role of dopamine in this? How many of you are using dopamine? Okay. You have a thought? Please go ahead.
Hello. Yeah. So what I feel that the in this case, if we like just give IV fluids, it won't work because there is some amount of LV dysfunction. As well, if I take out the RV dysfunction out of the equation, so with LV dysfunction we have to give some inotrope, and that inotrope NORAD is out because the SVR as Sir pointed out it's high, and if we increase the upload further,
yeah.
the output will fall.
Correct.
So another point is dobutamine we can't give because the patient is already in hypotension. So it can further worsen it. So I think dopamine in this case will be a good agent because it will be acting on the D1, alpha 1 and beta 1.
How much dose?
So dopamine in this case I'll start at around 10, the beta 1 dose to act. 10 mics per kg per minute.
I think, Dr. Sengupta.
Yeah, you are here.
I think when the etiology has not been established.
No, etiology is sepsis. The count is 20,000.
So if it is established.
It is a septic shock.
It's a septic shock.
Correct.
So definitely not only the fluid, we have to add noradrenaline, at least for the initial few hours. I think that is our classical approach. With vasodilation, in a septic, there is a chance of vasodilation. So whatever calculation we have done by year, so it is on the clinical ground, if it is a sepsis, if it is a hypotension, then it is very prudent to use IV fluid along with noradrenaline.
Right. So
No
I think,
question of giving dopamine or dobutamine
Okay.
right now.
So I think
Until
the-
other things are coming.
yeah, I think the main aim of this was, I will tell you what we did, but let me summarize that this is how you should approach, and this is a practical problem. So I just want to have a raise of hands after this discussion. How many for only IV fluids for half an hour? And watch. Please raise your hands. 1, 2, 5. We have 10 people. How many for IV fluids plus NORAD? After half an hour. Okay, we have 20. How many for IV fluids plus dopamine? You did again. 2 बार हाथ उठाया आपने. Okay, okay, first time. Okay. You have 3, 4 of us. IV fluids with dobutamine. None. Vasopressins. Okay, there is one. Why vasopressin, sir?
Underlying this thing of septic shock in this patient, following abdominal surgery. Like I'm a person from CTVS, we usually try and combine vasopressin baseline.
But do you start it on the first line after?
No, sir. In combination with IV fluids plus NORAD, after an hour or so of NORAD not raising the hemodynamics, probably the baseline vasopressin may help to increase the sensitivity for the receptors to.
Right. So thank you so much. So the main aim was this to approach. So the point is you have to perform the echo regularly in this patient. You can also get a central line. We did an uptitrate. The patient got a blood transfusion. He was started on IV fluids plus NORAD. So this is what is a practice. Unfortunately, you're right, sir. Very few people calculate SVR on day-to-day basis.
My question to you,
Yeah,
Shanti,
yeah.
would you give hydrocortisone to this patient?
Right. So one of the main, he's right. One of the mechanism of hypertension can be allergy or Addisonian's episode. It has been known, but I think as a critical care people, they are very afraid of having at the 20,000 counts to give hydrocortisone.
I think what is the class of recommendation for hydrocortisone in a patient with sepsis and low blood pressure?
Usually after 24 hours, because they are not responding to the antibiotics.
Absolutely.
So what has happened, you have covered with antibiotics
Yeah.
for a good amount of time.
Not at this time.
You still are having persistent antihypertension. It is a class 2 indication for giving hydrocortisone.
So usually on day 2 or day 3 people add.
Not at the first time, right?
Not at the first.
But you know, there are intensivists which I know of who would start right from day 1.
Yeah.
We have a strong group of individuals and well trained, not in, well trained abroad actually, who strongly believe in that. Yes, please go ahead.
According to the surviving sepsis guidelines, in the pediatric part, if the shock is not responding to catecholamines, that is the catecholamine resistant shock, then we have to add
Correct. So you
hydrocortisone.
start second day, not the first day.
No, sir, it is within first 1 hour, first half an hour for 1 hour, and next 3 to 6 hours. So
Actually-
we can't wait till the next day.
In fact, I entered into an argument with a senior intensivist some 6-7 years back, and then I read the books and he showed me the data. It's not a class 1 recommendation, but there is a good amount of evidence to suggest that hydrocortisone can tilt the balance in these individuals.
Yes.
And many of these people believe before you give noradrenaline after cover of antibiotics and fluids, hydrocortisone may be a better choice than giving actually noradrenaline, which especially if there is no evidence of reduced systemic vascular resistance could be deleterious for the organs. You will have more often creatinine will start rising. If you have very low systemic vascular resistance, by all means please give noradrenaline. But you have to calculate correctly and then keep observing the things. How is the SVR behaving? How is the cardiac output behaving? You might say, how would I estimate cardiac output? Just look at the LVOT VTI, nothing else actually. LVOT VTI will keep telling you how the things are happening.
One thing, Dr. Sengupta,
Yeah.
I like to add, in your initial evaluation, you have not included pulmonary embolism as the cause of hypotension in the fourth postoperative day. And echocardiography is a very good tool to exclude besides the biomarkers. So
Absolutely,
I think that
agree.
should be
Yeah,
taken into
absolutely.
consideration.
Yeah, absolutely, I agree. But this was one representative case.
Yes.
That you are correct, absolutely correct. Thank you so much. I
So,
hope it.
thank you, Dr. Sengupta, for a very good, offering a very good discussion. Now, we will call our next speaker, Dr. Devika Chatterjee. She is very well known, so needs no introduction. She will share us with her experience with a mass attached to tricuspid valve in a 37-year-old man.
Yeah, thank you, chairpersons, and thanks for that kind introduction. And good afternoon, everybody. So I'm going to show you a mass attached to the tricuspid valve in a 37-year-old man. We do see many masses in the cardiac chambers, but native valve masses are relatively uncommon other than infective endocarditis. But still, I have collected few and I'm going to show you. There is a patient who is 37 years old. Yeah, it's moving. 37 years old man complained of high-grade intermittent fever with weight loss for last 1 month. He gave us the history of dengue 6 months back, for which he was admitted in hospital and received IV medications and was discharged after 6 days. No history of IV drug abuse. On examination, he had fever, he had pallor, spleen was palpable. On auscultation, chest auscultation, the vesicular breath sound, and cardiac auscultation was normal heart sounds with no murmur. Now in the echocardiography in the apical four-chamber, as you can see in the tricuspid valve in the septal leaflet, there is a large mass having irregular shape with irregular margin attached to the septal leaflet, and a part of it is showing oscillatory motion, which is independent of the independent motion, out of phase motion, we say. And that mass was causing some amount of tricuspid valve regurgitation. So to see in detail, we did the transesophageal echocardiography, where we saw a large mass again in the septal leaflet, and a part was moving chaotically, part of the mass. And if we look at the TE picture at around 90 degree, you may see a abscess-like picture in the septal leaflet with a central, clear area. So my diagnosis was a possibility of an abscess. MRI was done. This also confirmed an abscess in the septal leaflet of tricuspid valve. His WBC count was high. Blood culture showed growth of Staphylococcus aureus. He continued to remain febrile, even with antibiotic, even after 7 days. Fungal culture was done. It was negative, but still empirically amphotericin was given, but continued to remain febrile even after 3 weeks of antifungal. And so he underwent the surgery where a partial valve repair was done, and he became febrile after 2 days of the surgery. So whenever we get a cardiac mass, in general, we should focus on the location, whether it's from the valve or it's in the chamber. And we always look at the imaging characteristics by echocardiography, and then we correlate with clinical presentation to reach to our conclusion. There are various causes of mass which may get attached to the tricuspid valve, and we can divide those into non-neoplastic and neoplastic. In non-neoplastic causes, if we see, it's mainly the infective endocarditis which gives rise to the mass in the tricuspid valve, so also thrombus and caseous necrosis. And in the neoplastic group, the benign tumors, including fibroelastoma, myxoma, hemangioma, lipoma, and the malignant tumors, like mostly the metastasis, or it might be a lymphoma or sarcoma. Though echo can identify these masses quite clearly, but it is unable to differentiate whether it's a thrombus or a vegetation or a tumor. So we need the help of multiple imaging modalities to find out the exact cause. Now, so far echocardiography is concerned, echocardiography of tricuspid valve is challenging because you see it has got 3 leaflets, but we cannot see the 3 leaflets in a single view by 2-dimensional echo. At a time, we can see 2 leaflets, which I am going to show you. Now, these leaflets are again having variable length and motion. The anterior leaflet is the longest and most mobile, whereas septal leaflet is the shortest and least mobile. Now, when we look at the tricuspid valve by transthoracic echo, as I said, at a time we see the 2 leaflets. In this apical 4-chamber view, we see septal leaflet and the anterior leaflet on the left side, and it is in the RV inflow view from the parasternal long axis with a posterior sweep, we see the anterior and the posterior leaflets. Whereas in the parasternal short axis view, again we see the septal leaflet and the anterior leaflet. And in the apical 4-chamber view also, I mean subcostal 4-chamber view, where is the liver, we see the septal leaflet and the anterior leaflet. Now let us see in the transesophageal echo, which are the leaflets we see in which views. Now in the mid-esophageal 4-chamber view, we see the septal and the anterior again, just like transthoracic 4-chamber view. And in the mid-esophageal RV inflow-outflow view, we see the septal and anterior again. And when we make a bicaval view, we see the anterior and the posterior leaflets. Bicaval view at around 90 degree or 110 degree. And also in the transgastric view at 120 degree, we see the anterior and the posterior leaflets. It is the 3-dimensional echocardiography which can demonstrate the 3 leaflets in a single view. This is the transthoracic 3-dimensional echo view. As you can see, all the 3 leaflets are seen very nicely, anterior, posterior, and the septal leaflet. Now let us see, let us look at the causes and see some cases. Now, if we look at the non-neoplastic, it's mainly the vegetation and abscess we come across in case of right-sided infective endocarditis, which is very uncommon if you compare with the left-sided infective endocarditis. But if we get the right-sided infective endocarditis, it is the tricuspid valve which is involved in 90% cases. The risk factors for right-sided infective endocarditis is, first of all, is the drug abuse, IV drug users, and also the cardiac implantable electronic device. It's a source of infection. It may come from the pacemaker pocket. We get to see many cases of pacemaker lead endocarditis, and indwelling catheters in case of chronic kidney disease patients undergoing hemodialysis, or the patients are taking the parenteral nutrition, chemotherapy, and also those who require long-term central venous access. It is the transthoracic echocardiography which shows, which is the procedure of choice, And we do see sometimes the masses in standard views, but often we need off-axis views with a sensitivity of 61% and a specificity of 94%. Now, if we repeatedly we get negative result in transthoracic echo, but we have a high clinical suspicion, we always go for transesophageal echo, and also in suboptimal window, because the sensitivity of transesophageal echo is as high as 90%. And also transesophageal echo gives us other diagnostic features like perivalvular abscess or the perivalvular regurgitation, etc., are better obtained by transesophageal echo. Now let us see some cases now. This is a patient. As you can see, the pacemaker lead is seen. A very large vegetation. Patient came with fever and with all the features of infective endocarditis, a large vegetation. It was a fungal vegetation. Initially, we couldn't see any vegetation in the tricuspid valve leaflets. And as we concentrated on the tricuspid valve, we could see, yes, there is a vegetation on the septal leaflet of the tricuspid valve measuring around 7 by 10 millimeter. So this is the vegetation which is due to the infection in the pacemaker lead, and which has involved the tricuspid valve also. The vegetation has caused some amount of tricuspid regurgitation along with the pacemaker lead. So that way you see the pacemaker lead infection can spread in the leaflet also. Here is another patient, 37 years, male, known CKD, on palm cath for last 1 year, admitted with history of fever, with high WBC and CRP. And look at the anterior leaflet of the tricuspid valve, a large vegetation. In the apical four-chamber view, it's on the left side, and in the RV inflow view, as you can see, this is the anterior leaflet of the tricuspid valve. So the mass is attached to the anterior valve. Now, if you look at the mass, it is attached to the atrial side of the tricuspid valve, because this is the lower pressure surface of the tricuspid valve, and right-sided vegetations are always larger than the left side because it carries the low pressure, and transthoracic sensitivity of detection of vegetation increases from 61 to 84% if the vegetation is more than 10 millimeter in size. And this large mass was causing tricuspid regurgitation as well as forward flow obstruction with a mean gradient of around 4 millimeter of mercury. Now, if we look at the prognosis of these patients with tricuspid valve infective endocarditis, it's much better than other form of infective endocarditis, but the fatality is lower. But if the vegetation size is more than 20 millimeter and the fungal etiology increases the mortality of the patients. And also the concurrent left-sided infective endocarditis make the prognosis worse. Thrombus in the tricuspid valve is possible, but very rarely diagnosed. I don't have in my stock, so I couldn't show you. But if you see the literature, you will see that it's possible following the placement of catheters in RA or RV. A pulmonary emboli, the thrombus, when it's passing through the right side, it may get entrapped in the tricuspid valve, and that way you may get a thrombus, which becomes very hazardous, and it often mimics the vegetation, so CT and MRI with contrast can only differentiate. Now let us see what are the neoplastic masses which we may come across attached to the tricuspid valve. Out of, all the primary, the masses, the primary cardiac tumors are extremely rare in the heart. Most are benign, only 1/4 is malignant. So now let us see one benign tumor. It is the papillary fibroelastoma. As you can see, we do see the papillary fibroelastoma in the mitral valve and the aortic valve. Those are having multiple long, thin finger-like projections like this. But in tricuspid valve, it's rare. And unlike vegetation, it typically spares the free edge of the valve. And patients are usually asymptomatic. Though these are having finger-like projections, the incidence of embolism in papillary fibroelastoma is very, very less. Differential diagnosis, the valvular myxoma, the tricuspid valve myxoma will come. I don't have myxoma, so I couldn't show you. I have myxoma in all other 4 chambers, even the mitral valve, but I don't have in the tricuspid valve. Those are usually globular when it is in the, I have one in the mitral valve. The shape is globular usually. And Lambel's excrescence also may come in the differential diagnosis. Those are usually smaller and they are more linear, and usually we get in aortic valve. Now let us move to the malignant masses. Most of the time it's metastatic, but very, very rarely we may get malignant tumors in the tricuspid valve like sarcoma, which accounts for 95% of the malignant tumor in the tricuspid, in the valve leaflets. Very poor prognosis. They survive for 3 months to 1 year, even with complete radical resection and chemotherapy and radiotherapy. Of course, the valvular myxoma will come in the picture in the differential diagnosis. Often it is very difficult to say whether it's myxoma or sarcoma. I'm going to show you a case which was operated in our hospital. A 37 years old male with no past cardiac history, presented with SOB in class 3 to 4 with swelling of legs and abdomen for last 3 months. On examination, pedal edema, ascites, and raised JVP were present. Auscultation loud T1 and mid-diastolic murmur over tricuspid area. Now let us see the transthoracic echo. The picture is distorted. I agree because patient was dyspneic, orthopneic, and the picture quality was like that. So this is the LV, this is LV, RA, and this is the RV. Now you concentrate on this area. A large mass is arising from the septal leaflet. As you can see, though the margin is not very clear in this picture, and if you see that this is causing, just 2 more minutes, sir, causing severe RVOT obstruction with a mean gradient of around 28 millimeter of mercury. So look at this flow, so narrow RV forward flow. We did the transesophageal echo. Look at the mass, it's much more clear now. Unlike myxoma, the margin is well circumscribed. It's looking like a capsulated mass, and it was attached to the septal leaflet, causing severe RV inflow obstruction. Again, we could demonstrate, and we found a very high gradient. So this patient, we really couldn't say whether it's myxoma or sarcoma. The diagnosis was confirmed only with histopathology. Patient underwent total surgical resection of the mass, tricuspid valve replacement with tissue prosthetic valve. Histopathology showed sarcoma. After that, the patient underwent radiotherapy and chemotherapy. And the sad part is that within 4 months, the patient returned to us with shortness of breath. In the echo lab, we saw, this is the picture, look at the tricuspid valve. though the mass is not very clear in these, but as I changed the multiplanar angle, I could see a large mass near this area. So this was causing total obstruction to the tricuspid inflow as well as to the outflow of RV, and with a gradient of around 9 millimeter of mercury. So to conclude, I would say that echocardiography can identify the masses in the tricuspid valve, but it really cannot differentiate between vegetation, calcification, and tumor. We often need the help of cardiac CT and MRI for their high resolution images with anatomical information, and finally the diagnosis is given by histopathology. Thank you.
Dr. Chatterjee, I just want to know what was the cause of abscess in the first case?
It was a Staphylococcus aureus infection.
No, but why should it reach from where? He was not a drug user. There was no.
No, the patient underwent IV medication when he had dengue 6 months back. I showed it in the history. So he must have carried the infection during that time. He was studying in Bangalore, a student of one famous science college there. So young, he was doing post-graduation, 32 years, 35.
Any more questions? So thank you, Dr. Chatterjee, for your informative presentation.
Thank you.
Now I call the next speaker, Dr. Dipanjan Bhattacharya, and his topic is stroke in a 35-year-old woman.
Hello. So good afternoon, everyone. So I'll try to make it a bit more interactive. So my talk is a stroke in a 35-year-old female. How useful is echo? So stroke in young adults. Young adults are defined as those who are having stroke between below 50 years of age. The studies, they define the population as between 15 to 49 years of age, and it accounts for 10 to 15% of all cases. Predominantly, they are ischemic. They are seen around 60% of cases, followed by subarachnoid hemorrhage in 22%, and other intracranial bleeds in 17%. So the common risk factors which are identified are dyslipidemia in 60%, smoking in 44%, hypertension in 39%. And cardioembolic stroke forms a major share in these patients. Various studies have documented the prevalence between 20 to 30%. So what are the causes of cardioembolism? They can be classified into major and minor. In major, the predominant cause is atrial fibrillation, then prosthetic valves, myocardial infarction, intracardiac thrombus, mitral stenosis, DCM with an EF of below 35%, LV aneurysm, and infective endocarditis. And the minor ones include a patent foramen ovale with a right to left shunt, an atrial septal aneurysm, spontaneous echo contrast in the left side of the heart, mitral valve prolapse, mitral annular calcification, calcific aortic stenosis, and ventricular akinesia. So coming to the cases, so since I was told the 35-year-old female, I've made all of the 35-year-old females. So 35-year-old female, known case of rheumatic heart disease since 16 years of age, had a history of stroke 1 month back. So anyone would like to comment on this? Yeah, sure. Yeah, so what we can see that the LA is hugely enlarged, and here we can see that there is something in the LA appendage. So this was the gradient across the mitral valve, and this is the magnified view showing the LA appendage clot. So case number 2, 35-year-old female again, so has history of recurrent TIA, has a clinical plop on auscultation. So these are the images. they'll run. So this is an easy one. Anyone wants to say? Yeah, it's a LA myxoma. So this is the plaques view where we can see the myxoma. It has got a typical heterogeneous appearance with spotty calcification. Case number 3, 35-year-old female, recurrent stroke, has been extensively worked up outside, lipid profile normal, MR angiography normal, thrombophilia workup is negative, transthoracic echo done multiple times, normal. Sorry. Wait. Anyone wants to try? Yeah. So PFO here we can see there's only a small jet on the transesophageal echo. So in this case we should go ahead with a contrast TE. It is nothing that but you make an agitated saline contrast. It can be made with 2 10 ml syringes and then you inject it forcefully into the cubital vein. So here you can see this is the LA, the one here is the LA and here is the RA. So within 3 cardiac cycles, the LA is getting filled. So if the LA is getting filled below 3 cardiac cycles, there is an intracardiac shunt. 4th case, 35-year-old female, dyspnea on exertion for past 6 years on diuretics, told to have some heart disease, papers are not available, had history of stroke 3 months back. I advise you to look at the clip at its full, then make a comment. With non-compaction will not lead to stroke. Anyone wants to try? Okay. So now with the contrast echo, it's a LV thrombus, which is clearly seen here. And here also, if I go towards the end of the, here we can see a tiny clot, which is hiding here. So we have to be very careful because LV thrombus are most often missed. Either we are not able to get the LV apex properly or we are doing cases too fast, so we are not making out. And contrast echo, yes, if we are having a high degree of suspicion, then it will bring out the picture. Okay, 35-year-old female admitted with hemiplegia, had history of fever with chills and rigor 2 weeks back, blood culture grew Staph aureus. So this is again a easy one. Anyone? Yeah, so we have a vegetation on the mitral valve. So this last case is unfortunately not a 35-year-old. It's a 15-year-old boy. History of cyanosis since childhood. Had multiple echoes done outside, was normal, was told as idiopathic cyanosis or something. Had a history of recent stroke. So we did something. So what did we do and what is there? I'll play both. Yeah. Saline contrast echo. Huh? Yeah, so actually we can see that the left side of the heart that is filling after 3 cardiac cycles. So that means there's an extra cardiac right to left shunt. And here if you are seeing this image, so we can see that the bubbles are coming from the right-sided pulmonary veins. So this patient underwent an invasive pulmonary angiogram. So there were extensive PAVMs in this patient and he underwent clogging. So what is the role of echo in stroke? To make it very simple. So this is the entire thing which I have already told. These are the parameters which we have to think. what can cause stroke, especially in young patients below 50 years of age. And this was a paper which was recently published in 2023. So they examined over 1,800 patients with stroke. 86% had a normal transthoracic echo. PFO they picked up in 5.2%, cardiac thrombus in 0.9%, vegetation in 0.2%, and atrial myxoma in 0.08%. So this was again a multicentric study where they found that patients who only underwent a transthoracic echo, around 37% the cause of was idiopathic. But once T was done, the number which was idiopathic came down to 29%. So there was a significant number of cases which were correctly diagnosed after a transesophageal echo. So what do the guidelines say? So it's a class 2A indication for use of echocardiography in patients with recurrent stroke and patients whom we are suspecting PFO and who are candidates for closure. So this again comes by the ROPE criteria, the ROPE score, where patients who, if they don't have hypertension, don't have diabetes, no history of prior stroke or TIA, non-smoker, cortical infarct on imaging, and a younger age. As younger the patient is, higher the score is. So a score of more than 7 indicates or tells that if there's a PFO, it has to be closed. But it's a class 2B that it says that the effectiveness of routine echo to guide treatment selection for prevention of recurrent stroke is uncertain. So these are the AAC guidelines on the appropriate use of TTE and appropriate use of TE. So appropriate use of TTE, they again tell if we're suspecting a cardiac cause of embolism, that is an indication for doing a transthoracic echo. An appropriate use for TE is, again, it's a supplement for to transthoracic echo. And it's an initial or supplemental test to diagnose infective endocarditis if there's a high test probability. And also an initial evaluation to facilitate clinical decision making with regard to anticoagulation, cardioversion, and or RFA for patients with AFib. So this was a paper which was published from the institute I trained in. So they analyzed all the patients with symptomatic large artery atherosclerosis and cryptogenic stroke. So they found that the patients who had cryptogenic stroke, likely cardioembolic, their mean TT-LA diameter was not significantly different from those with large artery atherosclerosis. However, when they compared those with recurrent stroke, they found that those with multiple events, they are having a significantly larger LA diameter as compared to those with having a single event. So what is my approach to a patient, to a young patient with stroke? First is a detailed clinical history with an examination, a 12-lead ECG, and if you're suspecting AFib, we can do a Holter. We can do a detailed transthoracic echo because that will give us a picture in most of the cases. And if it's not suspecting cardioembolic causes, we should rule out other things like hypercoagulable states. And if we are suspecting a LA appendage clot, a PFO with a right to left shunt, or a suspected vegetation not seen on the transthoracic echo, we can always go for a transesophageal echo. And if we're suspecting a right to left shunt, we can go ahead with a saline contrast echo either on TT or TE. So echocardiography is an important diagnostic tool in cases of cryptogenic stroke, especially in the young and those without comorbidities. Transesophageal echo increases the yield of cardioembolic etiologies, and saline contrast echo helps identify right to left shunts which are otherwise missed. Thank you.